The information presented in this presentation is not a substitute for examination, diagnosis, and medical care provided by a licensed and qualified health professional. The opinions expressed by this speaker do not represent those of AdventHealth. Please consult your physician before undertaking any form of medical treatment and/or adopting any exercise program or dietary guidelines. If you think you may have a medical emergency, call your physician or 911 immediately. Thank you for joining us for this AdventHealth virtual seminar. We hope you'll find the material presented helpful and informative.
Good evening. Welcome to AdventHealth Ocala's Listen to Your Gut Digestive Health Symposium. I'm excited to welcome you all virtually to hear from our panel of experts. By attending today's session, we hope that you will gain a better understanding of your digestive system and how you can take a proactive approach to your health. I'm excited to introduce our panelists today. Each panelist will have 15 minutes to present on their featured topic. Our first panelist today is Dr. Murad Bani Hani. Dr. Bani Hani is a board-certified and fellowship-trained surgeon with expertise in colon and rectal surgery. He specializes in minimally invasive colorectal surgical procedures. His areas of interest include colon and rectal cancer, inflammatory bowel disease, diverticular disease, and anorectal disorders. As a medical student, Dr. Bani Hani's father was diagnosed and cured of colon cancer by a colorectal surgeon, which inspired his medical career path. His education includes a Bachelor of Medicine, a Bachelor of Surgery, a General Surgery residency at the Jordan University of Science and Technology in Irbid, Jordan. Dr. Bani Hani also completed a residency at St. Agnes Hospital in Baltimore and a fellowship in colorectal surgery at the University of Buffalo, New York. Dr. Bani Hani?
Hi, I'm Dr. Bani Hani. I'm a colorectal surgeon at AdventHealth Ocala. I will be talking to you today about colorectal cancer. So the colon and rectum, and it's also called the large intestine, it's the part of the GI system when the food goes down through the mouth, into the esophagus, into the stomach, into the small bowel, and finally the large bowel. The large bowel, or the colon, responsible for absorbing water and electrolytes and some nutrients, and it's a store for the stool before the defecation process. What is colorectal cancer? It's cancer in general. It's an abnormal growth. In case of colorectal, it happens in the glands in the inner lining of the colon. And if it left untreated, it will continue to grow and it will spread outside of the colon. What is a colorectal polyp? Colorectal polyp, it's also a growth, but it's a benign growth. It's non-cancerous. It develops also in the inner or mucosal layer of the colon. Some of the polyps are benign and has zero chance to turn into cancer. Some of the polyps are precancerous, meaning if they left untreated in the colon, they will turn into cancer. And we'll talk later in the presentation about how important to do colonoscopy to remove these polyps before they turn into cancer. I'm going to go through common questions I get in clinic and in general. One of the questions is, how common is colorectal cancer? Colorectal cancer in the United States is the third most common and the third leading cause of cancer-related death. And the lifetime risk of developing colorectal cancer in the US is about 5%, which means 1 in 20 to 25 people will get diagnosis of colorectal cancer. Fortunately, both incidence and mortality of colorectal cancer has declined steadily in the past 3 decades, largely due to the effective screening programs that we will talk about and the treatment modalities. So the treatments of colorectal cancer has significantly improved, and patients do well even with colon cancer. Another common question is, how do I screen for colorectal cancer? I'm sure a lot of us heard so many different ways about to do screening for colon cancer. Colonoscopy is the most effective way because you're not only screening for polyps or tumors, you can at the same time remove them. There are other modalities like CT colonography. It's basically you get prepared like with bowel prep, like you're having a colonoscopy, but instead of having a colonoscopy, you have an X-ray that runs through, that scans the colon to find polyps. The good thing about it, if you want to compare it between colonoscopy, you don't have to be sedated, which most of the time you will be sedated for colonoscopy. The disadvantages are if you have anything positive on that CT colonography, you're going to have a colonoscopy to remove it or treat it, and it's the radiation exposure. There are other stool tests that could be done for screening, like the fecal occult blood or the immunochemical test. And what these tests they detect the hemoglobin in the stool, meaning they detect if there is any bleeding, even if it is on a microscopic level. Again, they are easy to be done. You don't have a bowel prep. But the issue, if they are positive, you're going to need a colonoscopy. And the disadvantages with these tests is there are a lot of false positives. If you have an inflammation of the colon, for example, you're going to have a positive test. If you have a bleeding from a benign hemorrhoidal disease, you'll have a positive test. And lastly is the stool DNA test, like, for example, like the Cologuard. It will detect the DNA that sheds from the tumor cells. Again, if it turns positive, we'll go back and do a colonoscopy. The sensitivity of this test is significantly good, 70–80%, if the polyp is more than 6 millimeters. So it will miss small tumors or polyps. What are the risks of colorectal cancer? There are risks that we can control, modify, and there are risks that we cannot control. The risks that we can control is the diet. Low fiber, high fat diet increase the risk of colon cancer. High red meat consumption increase the risk of colon cancer. On the opposite is low fat, high fiber diet decrease the risk of having colon cancer. Obesity, smoking, and heavy alcohol consumption are all risk factors for colon cancer that modifiable. Risk factors that they're not modifiable are increasing age. The older you are, the higher risk you are to have a colon cancer. Personal or family history of colon cancer or polyps, and inflammatory bowel disease like Crohn's disease or ulcerative colitis. Just to see how the age increases the risk of colorectal cancer, the older you are, the higher risk to have a colorectal cancer. And if you look at this curve, at the age of 50, the risk of colon cancer significantly increases, and that's why we recommend screening around the age of 50. I get these questions a lot about what are my risks for having colonoscopy? Should I have a colonoscopy? So in general, we divide the patients into average risk patient, with a patient with no risk factors, or a patient, including patients that have one first-degree relative with colon cancer but was diagnosed after the age of 60, because that's a common question. My grandfather or my father had a colon cancer. If they're at the age that above 60, you're not at increased risk of having colon cancer, so you can have a screening colonoscopy like an average risk patient at the age of 50. The increased risk individuals are individuals with the first degree relatives that diagnosed before the age of 60. And if you have multiple first degree relatives, regardless of the age, these considered are high risk, and they should get a screening colonoscopy at age of 40 or 10 years prior to the age of diagnosis of the family member. Say, if a patient's father had a colon cancer diagnosed at age of 48, the son or the daughter should have the colonoscopy done at age of 38, which is 10 years prior to the age of diagnosis of the father. How often should I schedule a routine colonoscopy? So that's take us back to the, are you an average risk patient or increased risk patient? For average risk patient, you start screening colonoscopy at age of 50, and after that, every 10 years, unless there are findings in your colonoscopy. Increased risk patients, like the patient we mentioned, patient with family or personal history of polyps or cancers, you start the screening at the age of 40 or 10 years earlier than the youngest diagnosis in the family, whichever comes first. What are the symptoms of colorectal cancer? And this is really important because about 1/3 of the colorectal cancer we diagnose, they have no symptoms. So these cancers are detected on endoscopy, whether it was diagnostic or screening. Again, just to reinforce how important to get your screening or diagnostic endoscopy done. 1/3 of the colorectal cancers we treat, they have no symptoms. If symptoms happens, they're usually vague. Patients have abdominal pain, described sometimes as colicky, mild, and progressively gets worse with time. Fatigue sometimes happen because patients with colorectal cancer have anemia, and that will make them fatigue or have shortness of breath. Weight loss, rectal bleeding, and changes in bowel habits are other common symptoms associated with colorectal cancer. Or they can present emergently if they have complications like perforated cancer or obstruction cancer or obstructed cancer. I was recently diagnosed with colorectal cancer. What is next? So when you're diagnosed with colorectal cancer, the first step for the physician is determine the stage of the tumor. The stage of the tumor is what's the extent of the spread of the tumor at the time of the diagnosis. To do so, we have to order some blood work and some CT scans. And depends on the stage of the tumor, the next step in the treatment will be surgery, which is most of the time, unless you have a stage 4 disease. If the tumor is already spread to a distant organs, the treatment can be sometimes chemotherapy, trying to see the response to the tumor, and sometimes you can downstage the tumor and go back to surgery. Role of radiation therapy in colon cancer is very limited. The role for radiation therapy is usually for rectal cancer and locally advanced rectal cancer. Minimally invasive colorectal cancer really changed the way we treat patients. Instead of doing the old-fashioned way, the open surgery, we now most of the time do the robotic or laparoscopic surgery. It's less pain for the patients, faster recovery, faster going back to your work, and less chance of having wound infections and hernias. It's just an example for incisions for patients we did right colectomy on, and on the right side of the screen, a left colectomy. Only small incisions, the only large incisions he or she will have is large enough to pull the specimen out. Now, what are my chances of cure from colorectal cancer? This is also a very common question. It's very important to know that most of colorectal cancer the cancers that hasn't spread yet are treatable, meaning they're a curable disease. And the 5-year survival for a localized tumor, meaning a tumor that in the wall of the colon but hasn't spread anywhere else, it's 90% cure or 5-year survival. If the cancer is a little advanced, meaning it's regional, it went through the wall, sometimes into the lymph node, but there is no distant metastasis, meaning the tumor stayed in the area, didn't go to the liver or the spleen, etc. You still have a very high chance of good outcome from the treatment. About 71%, you have 5 years survival, about 71%, which is very significant. Now, the unfortunate patient who have distant disease, meaning the disease spread into other organs. Let's say you have a colon cancer spread to the liver, the lungs, or sometimes to the brain. The chance significantly drops. Again, that's reinforced that you should get screened, get your diagnostic or screening colonoscopy done on time before the tumor is advanced. The more advanced the tumor, the lesser the chance of survival. Having said that, even with distant tumors, we've treated patients, for example, had a colon cancer with liver metastases. You treat them with, depends on the presentation, you treat them with chemotherapy, downstage the tumor, and take them for surgery, and we had some success on curing them. Common questions I get in clinic about also treatment of colorectal cancer is, will I need a colostomy bag or a stool bag? The answer to this, most of colorectal cancer cases, you do not require a stool bag. The only time we do a colostomy bag for emergency situations like the tumor is obstructed, the tumor is perforated, and it's only temporary. For elective colon surgery, for cancers, the chance that you will have a bag is very, very low. Now, for rectal cancer, it depends on the level of the tumor. If the tumor is above the sphincter's level, you will only need sometimes a temporary bag that could be closed. If the tumor is very, very low, meaning it's reaching the sphincter level, then that's the times that you will end with a bag, which is a very small percentage of the patients. Thank you for listening to this presentation. I hope it was helpful, and always remember to get your screening on time. Stay well. Thank you.
Thank you, Dr. Bani Hani. Our second presenter is Dr. Anthony Diorio. Dr. Diorio is a board-certified general surgeon with over 2 decades of experience providing general surgery care. He utilizes the latest techniques and procedures with minimally invasive approaches. He specializes in breast cancer and breast surgery, biliary and pancreatic surgery, and advanced laparoscopic surgery, including colon surgery. Dr. Deiorio also provides general surgical care of the gallbladder, hernia, and intestine. He earned his medical degree from the University of Miami School of Medicine and completed his internship and residency in general surgery and fellowship in interventional ERCP with liver and pancreas surgery and advanced laparoscopy at the University of Louisville Hospital in Louisville, Kentucky. Dr. Diorio.
Hello, everyone. As Ryan said, I'm Dr. Diorio. I'm a general surgeon here at AdventHealth, and one of my specialties is in biliary tract disease and ERCP. So I was asked to speak to you about that because it's a pretty common topic. Just a little bit of quick anatomy so you get an understanding of what we're looking at. Here in gray is what the liver looks like. There's a right and a left hepatic duct that combine to a common hepatic duct. The gallbladder then feeds into the common bile duct, which also feeds in the pancreatic duct and then into the intestine. This anatomy is kind of important when we start discussing how people present and what gallstones do, so I kind of wanted you to get a picture in your mind of what that looked like. There are variations in anatomy. Some very common ones are just where the cystic duct comes off. There are also some much more complex ones and the things that make actually this type of surgery challenging at times. So biliary physiology, what the liver does is it produces bile, and that bile is used for the digestion of fats and oils. The bile travels down the ducts and out to the gallbladder. In the gallbladder, it's stored and concentrated, and then just to give you an idea what the bile is made up of, it's made up of a phospholipid called lecithin, bile salts, and cholesterol. Those are all combined, and when we eat something, there's a hormone signal from the gallbladder, from the small intestine, the duodenum, to the gallbladder. This causes the gallbladder to contract and emits the bile down to the food. And what the bile does is that it emulsifies the fat. What that means is it breaks up the fat into smaller globules, increases the surface area so that the lipase enzymes can get at it better and help you digest your fats better. So the main reason I mentioned the components is if you look at this, I know this is kind of a busy triangle, but the three components, lecithin, cholesterol, and bile salts, are on the three ends of this triangle. This area down here under the green is where all the concentrations need to be for it to stay liquid. If the bile salts either decrease, or the lecithin decreases, or the cholesterol increases, all these three form stones, just to give you an idea of how that happens. What actually causes that to happen is a whole other question that we don't really have all the answers to, but we'll go through a few of those things later. So why are we talking about this? The incidence of gallstones varies pretty greatly throughout the world, from a low of 5% in the Asian and African populations to a high of about 30% in some of the European countries. Here in the United States, we're somewhere in the 10 to 20% range, which if you take the mean of that, 15%, it translates to almost 20 million people having gallstones in the US. 65 to 75% of those are women. It's more common in women than it is in men. Of those people who have gallstones, 80% will be asymptomatic. But that also means that 20%, or almost 4 million people, will become symptomatic at some point in time. So you're talking a huge number of people that need care. These are some of the risk factors for developing gallstones, and pardon the busyness of this slide, not all that important as far as individual things. I will tell you that general surgeons have a mnemonic that replaces this whole thing, and that is the 5 Fs. Female, 40, overweight, fertile, and family history are the 5 things that generally predispose you to gallstone disease. So what symptoms do gallstones present with? Again, think back to that anatomy picture, because it depends where in the anatomy the stone lodges as to what kind of symptoms it causes. So if the gallstones are simply sitting in the gallbladder doing nothing at all, you're asymptomatic and you really don't need to have anything done. If they are at the exit point of the gallbladder temporarily, you get what's called biliary colic, and that is when you eat, you get an intermittent, after eating, upper right and central abdominal pain. Usually radiates into the shoulder and shoulder blade, lasts for minutes to hours, and it's possibly associated with some nausea and vomiting, but it alleviates itself over a short period of time. Acute cholecystitis is kind of the next step up. The stone lodges and it stays there, and so the symptoms are similar, just more severe. They're sharper, ongoing for longer periods of time, greater than several hours, and often associated with fevers and chills, particularly as the inflammation goes on. Cholangitis is now where the stone has passed from the gallbladder into the main bile duct, blocks up the bile duct, and that produces a right upper quadrant and central pain that radiates into the back. It's associated with jaundice, dark urine, and light stool because of the blockage of the bile duct, and again, fevers and chills because of the infection. Cholangitis is a much more serious disease and can actually lead to sepsis and death of the patient in a very short period of time. In fact, sometimes within 24 hours. So it's something that needs to be addressed rather quickly. Pancreatitis, if the stone gets further downstream in the duct, it can block where the pancreatic duct came in at the bottom. And that is epigastric and left upper quadrant pain as the pancreas gland kind of extends to the left and back. It's associated with nausea and vomiting as well as fevers. And this too can go anywhere from mild to severe. The severe forms can be life-threatening. So you can see where stones passing into the duct is actually more risky than stones staying in the gallbladder, generally speaking. And then there's a rare entity called a gallstone ileus, where a large stone erodes from the gallbladder into the small intestine and rides down the small intestine to where the valve empties into the colon. It blocks the small intestine, and so it presents like a bowel obstruction with crampy abdominal pain throughout the abdomen and incessant nausea and vomiting. So how does your doctor get at the diagnosis? Well, the key to it is always the history, physical exam, and labs. Historically, he's going to look for the symptoms that we just discussed. Physical exam, he's going to be checking to see where the pain is, how bad it is, and lab tests are going to tell him whether the liver functions, pancreatic functions are elevated or not. And then he's going to perform some x-rays to kind of determine what we have. So this is a typical ultrasound of the gallbladder, and the machine is up here, and it casts an ultrasound down through the abdomen. This dark area right in here is the gallbladder. The dark part is the fluid, and this right here is a stone sitting right in the emptying point of the gallbladder. Interestingly, on this one, you'll notice there's a little gray outline here that's much thicker than it should be. This patient actually had inflammation of their gallbladder, and you can actually see that on the ultrasound. If we can't see it on the ultrasound, we'll do a Heida Scan. Now, Heida Scan means we're going to inject a nuclear medicine tracer into the vein. That's going to be taken up by the liver and then excreted down through the biliary tree. So what you develop the image of is the liver itself. Remember the anatomy we talked about, the right and left hepatic duct coming to the common duct and emptying into the small intestine. And in this one, you can see the gallbladder kind of hanging off to the side. Now, if you had acute cholecystitis, there's a blockage right here of the stone, and this part looks clear or white. So you can kind of make the distinction that way. And then lastly, if we think there may be a stone further downstream in the bile duct, we can do an MRI of the biliary tree. This shows a pretty classic right, left, and main hepatic duct, the gallbladder off the edge, the pancreas duct coming in, and the bowel right here. And again, the abnormal one with these 4 densities down in the duct, all lined up. These are all stones in the common bile duct. So what's the treatment of the different entities? Again, if you're asymptomatic, you really don't need any treatment at all. The only time that we ever recommend treatment in an asymptomatic patient is if they're diabetic with neuropathy or they're on steroids, because those can actually mask the symptoms they're supposed to be feeling, and so they can actually be sick without knowing they're sick. With biliary colic, there are 2 different options. One is to alter the diet in a way that lowers the fatty food intake and thus stimulates the gallbladder to contract less. You might be able to take care of the symptoms. Now, this is a pretty reasonable approach for a short period of time. It's not a great approach for a long period of time because people tend to drift back to their original diet very frequently, number one. And number 2, the gallbladder will actually become more and more sensitive to the non-fried and fatty foods as time goes on, and then potentially get more symptoms. Ultimately, we usually wind up falling back on removing the gallbladder or cholecystectomy. With cholecystitis or inflammation, the treatment's going to be antibiotics and pain control initially, and then usually followed by cholecystectomy. The exception to that is if you have a patient who is too infirm to undergo the surgery, and it may be a temporary problem or it may be a permanent problem, in which case you can actually drain the gallbladder, alleviate some of the pressure, treat with the antibiotics, get the symptoms better, and then come back to fight another day if it's a temporary problem, and if it's a more permanent problem, just hope that he doesn't recur the symptoms. Cholangitis, as we said, this is a little bit more urgent. We got to get the antibiotics started right away and then perform an ERCP. ERCP stands for endoscopic retrograde cholangiopancreatography, and that's a 25-cent word that basically means we take a scope and look backwards up the bile duct. We're able to make small cuts and remove stones and put stents in and do certain manipulations that will alleviate the obstruction, which together with the antibiotics will take care of the infection. Usually that's going to be followed by taking the gallbladder out so that we eliminate the source of the stones so it doesn't simply recur again and again. Pancreatitis, similarly, the only difference with pancreatitis is we need to treat the pancreatitis differently than we do the cholangitis. Part of the problem with cholangitis, you have to get the drainage done in order to get it to get better. With pancreatitis, you actually want to do nothing first. You want to let the pancreas rest, no food, nothing to drink, so that there's no stimulus to the pancreas gland. And then we're going to treat with IV fluids and time and allow the pancreatitis to settle down. Once that settles down, we usually will follow that up with cholecystectomy. Now, rarely ERCP is used to alleviate the blockage there. We try not to use it with pancreatitis because, unfortunately, one of the side effects of the ERCP is it actually can make the pancreatitis worse. And so we only keep that in reserve when the pancreatitis simply isn't getting better. And then gallstone ileus is a different focus entirely. We're focusing on the problem with the bowel. That needs bowel surgery to open the bowel, remove the stone, close the bowel. And you actually don't necessarily have to take the gallbladder out because it's already kind of spontaneously drained itself into the intestine anyway and isn't likely to form another large stone that way. So the three ways that we can address the gallbladder surgically afterwards is an open, a laparoscopic, and a robotic technique. Just to kind of compare and contrast, the open technique is the oldest technique. It is still a very good operation, but it does take a long time to recover from. Generally speaking, it's somewhere on the order of 4 to 5 days in the hospital and somewhere on the order of 4 to 6 weeks before you're fully recovered. And that's why the laparoscopic procedure came around, because people wanted to get better faster. So laparoscopic and the robotic procedures are done internally through small incisions. The steps on the inside are exactly the same, so it has the exact same cure rate, the exact same complication rate. So everything about the surgeries are identical, except the recovery is much faster. With the laparoscopic and robotic, you're looking at a one-day stay or an overnight stay in the hospital and somewhere around a week or so before you feel like yourself. Now, there are about 3% of the population that have to be done open if the gallbladder is terribly inflamed, if it's scarred in, if there's one of those terrible anatomy variants that make it real difficult to dissect out the bile duct. Those generally have to be done open, whereas the laparoscopic and robotic account for about 97% of our procedures. So just to give you an idea of what those look like, and forgive me, this is a little out of focus, but the open gallbladder leaves a scar in the right upper quadrant, right underneath the right rib cage. The laparoscopic is generally 4 small incisions. These are about a ½ an inch in size. This one is about 1 inch in size. The robotic actually has a 4-port robot, which leaves 4 scars, 1 at the belly button and 3 across here. And then there's a single incision robotic, which is actually the only reason I use the robot is for the single incision. And I'll show you that in real time here. Mostly what I want you to get out of this diagram is that the reason we do this open is that you can actually get a hand down in there. You're not just depending upon your vision and feel of instruments in order to tell where the structures are. You can actually reach your fingertips in there and feel the different structures when you can't see them well. And that's its biggest advantage. So again, when it's inflamed, when it's scarred in, you're going to add the sense of feel, and that's what's going to give you the advantage of being able to do this safely. And just a picture of what that looks like when we're in surgery. Laparoscopic, we've got the small ports up here. Now this particular surgeon is 1 port short, but that's okay. Camera in here, and this is an idea of what view we get. They've grasped the gallbladder here and lifted it up, so you're seeing the undersurface of the liver, gallbladder, there's the cystic duct, there's the common bile duct and common hepatic duct. I promise you, you'll never see it this clearly anywhere else except for this picture. Every general surgeon would love to see that every time that they do the surgery because it just makes it that much easier if it's that clear. It just isn't always that way. With the robot, this is that 4-port I was telling you. Now this is a little different. We're looking down towards the feet here. So this is the belly button, has the camera in, and these are the 3 ports down here. Those ports are then attached to the robotic arms, and there are instruments that come in through those ports that are attached to the robotic arm. The surgeon, after he gets that set up, goes to an instrument panel that's away from the patient. It could be miles away, but in our case, it's simply in the same room right next to the patient's bed. And then by manipulating these little pincers with his fingers and wrists, he basically works all those instruments on the inside and again does the same operation. I personally have not found the 4-port robot to be any more helpful than the 4-port laparoscopic, so I tend to do the 4-port laparoscopic. It's just easier on the OR crew. But I do use the robot for one condition, and that's for the single incision. The single incision has this one silicone port and all the instruments go through that one port. Now it's a little bit trickier because those instruments are actually curved so that they will reach out and triangulate at the gallbladder and allow you to do the surgery imitating the different approaches from side to side and from the front so that not all the instruments are coming from one direction. And what it leaves you with is this one little incision at the belly button, this one little scar. It is generally used for thin people or people who are very concerned about scars. Most of our gallbladder patients are heavier and probably not a great candidate for this because it's much more difficult to do in heavier patients. With any of the 3 types of gallbladder surgery, we'll often do a study of the bile duct. I will do this routinely. And basically what we're doing is we're injecting dye through the cystic duct and lighting up the entire bile duct so that we can see whether or not there are stones in there. So what we do for the common bile duct stones depends on what we find and where we're at. If we're doing an open surgery, we can simply do an open common duct exploration. Or if the stone is very large, we can switch to open in order to do it that way. Now that, of course, necessitates the longer recovery and drains in for a longer period of time. So it's not ideal as far as recovery goes, but again, still a good operation. Laparoscopically, we can now do laparoscopic common ducts. My favorite is the transcystic, in which case we put a balloon into the cystic duct to make that larger. And that allows the stone to kind of move in and out, and then we can actually work through that duct with really fine filament type cameras and scopes, grasp the stones and draw them back out. Now those stones have to be reasonably small in order to come backwards up that cystic duct because that duct is fairly small. And if they're in that mid-range, not the big ones that need open and not the small ones that can come out laparoscopically, I'll do an ERCP, which is that same procedure with the scope where we go up backwards and extract them from below. And I'll give you an idea what those look like. Now the open common duct, I don't think I have any pictures of, but this is the laparoscopic. So what we do is we make, again, here's that anatomy we talked about, make a little incision in the duct here, put the camera down, and go into the bile duct. Now they show this with an instrument guiding the camera. I actually use a wire, so I send a wire down first, and you can see the wire kind of coiling down there. And then this thicker part is the camera, and the tip of the camera is sitting right there in the bile duct. And what we're looking for is this little light area down here. When you put the camera in, this is what it looks like. Here's 2 stones sitting at the end of the bile duct. Now, just to give you an idea just how fine these cameras are, this duct is only about 4 to 5 millimeters across, or 1/4 of an inch. And the stones are even smaller than that. They look like boulders on this, but they're really not that large. And then we can grasp those stones and draw those back out to alleviate the blockage. If we can't do it that way, if it's one of the larger stones, then we can utilize the scope. Now this is a very classic kind of endoscope that we use. It's very similar to the upper endoscope that we use for ulcers and for looking at the stomach and the duodenum for gastritis and those sorts of things. Just to give you an idea size-wise, that's about the width of your index finger, to give you an idea. The thing that is unique about this scope is that it has all the cameras and all the instruments exiting the side because of where you're going to attack with the scope. So driving it is a little bit more complicated, and I'll show you what I mean by driving it. You have to get the scope down through the esophagus, the swallowing tube, through the stomach, and into the small intestine, and then look sideways out at the bile duct. And what we're looking for is this. This is the papilla, or the ampulla vater, where the duct's empty. That's the opening right there. This is about 3 millimeters across, or about 1/8 of an inch, and this is even tinier. So you can imagine how difficult it is to get something to go backwards up that area. Ultimately, what we're trying to do is this: get a wire back up there, get the catheters up, and then work through that. We're successful with this about 90 to 95% of the time. I tell people this is extremely challenging if you think about the sizes you're working with, and kind of the best common day ritual that you can think of that may predispose or allow you to think of what we're doing. I tell people it's like picking a lock from 3 feet away with a wire. But what we can accomplish, you can see what I've done here is I've got my scope in a nice position in the duodenum. I've got my catheter going backwards up the bile duct. There's a little stone right there. And then what I do is with that catheter, I have a little banjo string on that. I tighten the banjo string. We run a little electricity through there and make a cut to open up that end of the duct so it's big enough to allow the stone to pass out. And then once we get it large enough, we put a little balloon up above it and draw the balloon back, and that allows the stone to pop out. If the duct is too big and the balloon pops past the stone, we have baskets that we can put up there and grab onto the stone and actually draw it out that way. So now that you know everything there is to know about gallstones forming, what symptoms they present with, how we treat them, there are two common questions that I get, and I just wanted to cover these real quickly for you. So when it comes to flushes, stone-dissolving agents, and lithotripsy, I group flushes and lithotripsy kind of together. The idea is that you're shrinking the stone and allowing it to pass from the gallbladder into the bile duct and preferably out into the intestine. The problem with that is, if you remember, we talked about the stone diseases that actually go into the bile duct. Those are potentially more dangerous to you than the ones that are in the gallbladder. And so it's probably not a good idea to do that because you're treating a more lethal condition for something that would have been less lethal otherwise. In addition, people think of the lithotripsy as what they do with kidney stones. Well, when you crush a kidney stone and pass it, number one, there's no place else for it to catch on, and so it generally just passes right out. It doesn't cause a problem. But number two, you're not likely to form another kidney stone for several years afterwards. Whereas we know with gallstones, if you do lithotripsy, you're probably going to form more gallstones in about 30 days. And so you're really not succeeding at alleviating the gallbladder for any long period of time. So what I tell people all the time is, don't. That's just a bad idea. You'll read about it on the internet, everybody will talk about it, but it is a bad idea. There's only one time when it isn't, and that's when we use these stone dissolving agents. When somebody's too infirm to undergo surgery and they have gallstones, the stone dissolving agents may be the only thing that they can use. They are expensive. They take a long time to work, in excess of 6 months. But if it's the only option that you have that's legitimate, that may be the only thing that you can fall back on. And then lastly, people ask me about gallbladder cancer. Do gallstones cause more problems with gallbladder cancer? So to start, you have to realize that gallbladder cancer is extremely rare. You're talking about 1 person in 100,000 in the United States, more common in women, less common in men, and significantly more common in the native Eskimo and American Indian population. But even in that significantly more common, you're talking about only 4 cases in 100,000 people. It's pretty rare. So gallstones do increase the risk of gallbladder cancer. The gallstones have to be in place for greater than 20 years, generally speaking, for that to happen. So it has to be somebody who's young and is going to live for a long period of time to keep the gallstones in. And what it does is it's making a rare cancer slightly less rare. It is not taking it to common in any stretch of the imagination. So most surgeons really don't use that as a reason for removing the gallbladder, but some do, particularly in young patients, but obviously in older patients it's probably not necessary. Of note, the gallbladder cancers do tend to be very aggressive, and that's why they do kind of argue in the young patients to go ahead and get rid of them. Any questions? I'd be glad to answer them.
Thank you, Dr. Diorio. Our final panelist today is Devin Breedon. Devin is a registered dietitian with over 8 years' experience in nutrition and management of chronic diseases. He oversees both clinical nutrition and diabetes at AdventHealth Ocala. Through his experience, he knows that the food we eat has a direct effect on the body's ability to digest nutrients and provide good energy. He has experience in diet modifications to manage diseases such as IBS-D, diverticulitis, SIBO, diarrhea, constipation, and short bowel syndrome, as well as many other gut-related diseases. As a dietitian, he reinforces that all health starts in the gut and that its importance is not always well known. His motto is, if the gut works, use it. Devin?
As Ryan had mentioned, I am the clinical nutrition and diabetes manager, and I have been a dietitian for the past 8 years, handling a lot of different conditions, including a lot of gut health concerns. It's important to know that when we talk about the gut and what we absorb, it's really not about the whole adage of you are what you eat. We really need to think of it as you are what you absorb. So we'll talk about that today in regards to what the gut actually does and how we can benefit our own health. What is gut health? So this has been a big term this past few years, a big buzzword. Gut health really means everything that happens from your mouth and to the other end of your body. So it's really what happens in between. Some people think that guts are related to our stomach, but really the gut actually, the stomach is only a small part of our gut. We move on to the intestines and obviously the small and large intestines. that make up the entire gut. And our gut is made up of many tiny microbes, different things that obviously make up the gut, help us digest our food, break down what we eat, help us produce energy for our bodies. Your diet, medications, your body fat, and mental health all play a role in how your gut is going to function. So it's very important to know that it's just not about diet, it's about the other things that affect your gut function. The main function of our gut is to ferment the food and the source of fiber that we take in our body. And what the body does, it takes that fiber and it breaks it down into microbes, into energy, and into a lot of different gases that will benefit our body in the way that it functions. Gut health is money, and there's multiple reasons for why we talk about money. The average American is spending a lot more money on gut health than most other medical conditions. And a lot of the supplement companies are taking advantage of that, to the tune of about $358 million in 2016. And based on data and based on taking this information into the future, by 2025, we're going to see this to be a $1 billion industry. So for people to spend their money on something that they think is going to benefit their gut, they might be throwing it away, and we don't really know if there's benefits or not. So it's very important to understand that there's a lot of money being put towards this. When we look at gut health and we look at supplements, it's important to know that the FDA and the term gut health is not regulated. So a lot of the supplement companies that are out there are going to sell you things that may not truly be in the products that they are marketing. So it's very important to know that if sometimes it's too good to be true in some of these supplements, it probably is, and probably should ask an expert if those things are beneficial. The annual expenditure per year for gut health and gut-related issues, or GI issues, has exceeded most other medical conditions to the tune of $136 billion. And that number is only going to increase as more people develop GI issues. That is exceeding things like heart disease, trauma, and mental health. Some of the top things that we feel as Americans are concerned have been superseded by gut health and gut-related issues. And of late, we've seen a large increase in the use of a lot of food-based testing, intolerances, sensitivities. You can go to any store and see on the shelf a test for food illnesses, food intolerances, food allergies. And we actually see people physically come to our offices and bring these lists to them and say, I'm allergic to everything under the sun. And the problem with most of these tests is they don't really tell you really what's going on with the patients and the people that bring them in. It's very important to see how we digest these foods and do things one at a time. Most of these tests really just tell if your body's producing a response to something, not really telling you that you're allergic to it. So be aware, a lot of those tests are pretty misleading. There's no wonder why most Americans are starting to question things, but they're also trying to find any magical thing that's going to fix their gut, make them feel better. We have plenty of people that would eat something and say, I feel pretty tired, I feel pretty lousy. So when they're told this magical pill or supplement is going to alleviate those things, it sounds so good that some people will do it because they don't want to deal with the GI issues going on. Fad diets remain a dietitian's worst nightmare. We have people that follow these extreme diets where they cut out certain food groups, namely with keto lately and obviously gluten in the past few years. We're seeing where people are cutting out a lot of the foods that they eat, and their guts aren't being given what they need. So it's very important that we see that people eat all food groups and all things that are beneficial to them. What has the American diet done to our gut? All right. There's no mistaking that we do not eat healthy as Americans. Most people eat fast food, and then some people eat it in absorbent amounts. What this is causing with most people's gut health is that we're eating a lot more animal products. We're eating more saturated fat. We're doing refined grains over whole grains. We're increasing our sugar, our salt, our alcohol. All of these things, as well as some of the things like corn-derived fructose, which is added to a lot of our food. We shift from a good intake of fruits and vegetables to a lot of these processed and refined things. So what happens is our gut doesn't have a lot of diversity. We're not seeing those enzymes that are activating the body. We're not seeing the normal processes. We're starting to see things like gallbladder issues, like Dr. Diorio had mentioned earlier. We're seeing those concerns going on. We're seeing more infections. We're seeing inflammation. We're seeing a lot of autoimmune concerns going on because the food is dictating a lot of the inflammation in our body. We're seeing issues with the mucosal layer of the stomach deteriorating with a lot of the food and some of the medications that we take. This deterioration actually results in the body's ability to not take as much in when we're consuming our food. So we'll see as we get older that we're seeing more people develop issues with B12 deficiency because the stomach acid and the lining of the stomach has deteriorated so much that we see anemia with our patients. We're also seeing an issue with low short-chain fatty acids. Those play a role in a lot of the energy production, a lot of the processes in our body. It's important to know that the studies are showing recently that within 4 days of going to a primarily fast food diet to more of a Mediterranean style diet, we're actually seeing most of these issues reverse within 4 days. So there's no reason why we can't look at doing things out, make the trend go in a different direction. It all comes back to fiber, okay? Fiber is key for gut health. There's no magic pill, there's no magic supplement, it's fiber. And fiber in its truest form is either going to be the form of soluble or insoluble fiber, okay? It's important to know that there are 2 different types of fiber because both of them benefit the body in different ways. As I said, all roads lead back to fiber, getting fiber in your diet. Most people think of, when they think of fiber, they think of moving their bowels and their body going. But fiber actually provides the energy for the good bacteria in our gut to do what it needs to do. So it's important to know that we get enough fiber. So now the 2 sources of fiber are soluble and insoluble fiber. Your soluble fiber is the fiber that's going to absorb water, okay? It's going to take in some things to help you digest your food. Your insoluble fiber is going to actually break down in water and help pass the food through your body. So having a combination of those 2 things allows the gut to do what it's supposed to do and produce energy, all right? The good thing is most plants contain fiber. Almost all of them contain fiber, and that means fruits and vegetables. And we also obviously want to make sure we look at whole grains as well. All 3 of those things produce the fiber that we need to feed our good bacteria, all right? It doesn't take a magical pill, it doesn't take a supplement, it takes the fiber from our food, okay? Unfortunately, with all good things, there may be some bad. So too much fiber is actually a concern. So if you are looking at increasing fiber, you must also increase fluid, okay? As I said, some of that fiber pulls in fluid and pulls fluid to the body, so you have to replace that fluid that you're going to lose when you consume fiber. So it's very important. With fiber intake comes fluid intake. We want to focus on probiotics and prebiotics. We want to make sure that we are seeing a benefit in those to make sure our guts are working. It's important to know that with a combination of both, our guts are going to be working optimally, okay? Prebiotics, as I said, is also known as fiber, is going to help absorb nutrients. It's going to feed existing good bacteria. And the good thing about this is you can get it in your diet. You don't have to take a supplement. Having said that, if you know that your diet lacks fiber, things like Metamucil that we see some of our older patients take may be beneficial if you feel like you're not getting enough fiber in your diet. So be aware, if you can't get it in your diet, there is a way to get it in supplements. But our goal as dietitians is we want to make sure that you're doing it in your diet first. Probiotics are going to come from things in our diet such as fermented foods. So typically we think about taking a pill, we take a supplement for probiotics. A lot of our fermented foods, things like kombucha, kefir, even sourdough bread has active bacteria in it that actually will help feed our gut and make it work a little bit better. So we can actually get most of that from our diet. So be aware, food always comes first, supplement should always come second. So if you know you're getting your diet a lot of good fermented foods, a lot of good fiber, a lot of fruits, vegetables, whole grains, supplements aren't really that necessary. So there's no hurt in taking supplements. And as a dietitian, I tell most people, if you feel like you're not getting enough in what you're eating, supplement it. It won't harm you unless you know there's a medical condition that requires you to not take supplements. How do I fix my gut? So what are the next steps to take to fix someone's gut? Okay, because we can reduce some of the issues and some of the inflammation, but it takes multiple things, okay? It takes fruits, it takes vegetables, okay? Those are the main 2 sources of fiber in your prebiotics. Those are going to feed and give you good energy. And I tell most people, you want to have a combination of, typically the vegetables, you want to make sure you have raw and cooked vegetables, okay? Because it's giving you that insoluble and soluble fiber. You have to have a balance between both of those things. That leads obviously the general need for fiber. If you're not getting it from fruits and vegetables, you find it from a supplement form. We want to focus on plant-derived proteins. What we're seeing in America is that we're a very heavy meat society, and what happens is that meat takes a lot more time to digest. So it's very important that we look at options like nuts, seeds, for our option for protein that's more plant-based, that actually is going to help reduce a lot of that decreased motility in our gut. So it's important to make sure we have a balance of plant-based proteins. We want to make sure we have omega-6s and omega-3s. Those come typically from a lot of your nuts and seeds as well as good fatty fish. So be aware, most of those fats that we take in from omega-3s and 6s actually feed a lot of the enzymatic processes in our body to help us digest our food and to decrease inflammation. And not to mention, they help a lot of other medical conditions like heart disease as well. So it's very important to know that fiber plays a role in a lot of other medical processes in the body. Key takeaways from the talk today is that gut symbiosis is important. That means that the gut, we're taking in the energy that we need. The gut is doing what it needs to do. And then we're actually making sure that we're providing the right energy for a lot of the processes in our body and that the organs are doing what they need to do. Okay, as I said, everything starts with your gut. If you feed the gut right, a lot of the other things do what they're supposed to do. Fiber is your friend, okay? It's not just for getting things to move through your body. It feeds the body. It gives it the energy. So it's very important that if you know you don't have adequate fruits and vegetables, you don't have adequate whole grains, try to do that in what you're eating. Poor lifestyle choices. So as I said, intake of sugar, fat, alcohol, fast food, those will dictate the way your gut works. So making little changes here and there and setting goals to make improvements is going to do a lot for you in the long run in regards to health. We see a lot of issues later on in life because of the concerns that we had with our diet early on. So it's very important that for a lot of our younger people that want to prolong life and make the best of it, to make sure that we're focusing on good, healthy things that are going to be full of fiber and help benefit the gut. The medical community, as you guys have seen today, we're focused on making sure that diet and the way that gut works is an important part of the medical treatment that we're doing. A lot of our medical conditions, as Dr. Diorio mentioned about the gallbladder, a lot of the risk factors for those issues is nutrition related. If we improve our nutrition, we improve our fiber intake, we make the gut work, we see a lot of these concerns decrease. And we see a lot less admissions to the hospital and a lot less need for any interventions like surgery. The American diet and the westernized diet, what we're seeing here is it plays a big part in the decline in gut function in the US. If there was one ideal diet or one way to fix some of the issues and improve, is following a Mediterranean-style diet, making sure that we have a good amount of lean meats, fruits, vegetables, whole grains, good fatty fish. That type of style of eating is going to promote the best for our gut, the best for our mind, and the best for our overall health. As I said, if you feed the gut right, everything does what it's supposed to do. And if we take the right things in, we absorb the right things and benefit our health. I've been asked by many people if you can be gluten intolerant and lactose intolerant at the same time. Our role as a dietitian in handling nutrition is that we want to do things person by person. So we cater to whatever's going on with them. Now, having said that, with gluten intolerance, with patients that typically have celiac disease, we do see a higher prevalence of a lactose intolerance because the gut cannot break down things because of an issue with lactase enzyme in the body. So it is prevalent with those patients because we do see it. Some things that you can look at to make sure that it's one thing or the other. Typically with a lactose intolerance, you're going to have a lot more gas, bloating, and pain after taking in milk products. That's one of the main symptoms of having lactose intolerance. Now, gluten intolerance, there may be some gas or bloating, but typically patients will have more of a brain fog. They'll feel foggy, they'll feel tired, they'll feel fatigued. They may also have issues with pain. If they have chronic pain issues, sometimes we see inflammation from gluten in the form of their food that may result in some of this inflammation. So you can definitely have both things at the same time. We just look at symptoms as dietitians to make sure that we address what's really going on with the patient because everybody is very specific. Another question that I'm asked is, what is the best probiotic? If we're going to take one, if it's going to benefit us, what is the best probiotic that we're going to take? This depends on the symptoms of the person that we're seeing. Usually, like medication or like antibiotics, we have a certain antibiotic for a certain infection, a certain bacteria. The same goes for taking a probiotic. There are certain probiotics that are catered to certain conditions. The most common types of probiotics that we will see that people will take is lactobacillus and bifidobacterium. Both those have shown benefits for mostly diarrhea, and the bifidobacterium for more of a constipation-based issue. So it really depends on the severity of what's going on. We do see people of IBS that have a specific probiotic called VSL3 that actually is made for IBS patients. So it really depends on the conditions of what's going on. So it's very important to make sure that you explain your symptoms to your provider, to your dietitian, and then we cater to those symptoms. Another question that I'm asked from a lot of people is, how do I know I have an unhealthy gut? You know, is there testing? Is there something I need to look at? What we look at as dietitians, we look at symptoms. We look at what's going on with the gut when we eat food, okay? Do we have gas and bloating? Do we have constipation and diarrhea? Do we see more reflux with the food that we're eating? Then can we cater and look at what is specifically happening with our people? We'll take in an issue with what food they're consuming, if we have to eliminate certain things, and then add them back in. What we're seeing with a lot of conditions, such as IBS and those kind of things, is utilizing something called a low FODMAP diet, which is catered specifically to eliminating all the things that cause gas and bloating in our body. And then we bring back food one at a time to make sure that the gut's working the way it should. So it's really symptom-based, but those are all signs of an unhealthy gut. The final question I'm asked that is asked a lot of me is, what is the role the dietitians play in managing gut health? And this is a loaded question. As dietitians, we really assess what's currently going on with the patient, from the food they eat to the symptoms they complain of, to then looking at maybe other external factors like stress or medications. It's really based on all the things that play a role, all the environmental factors, and obviously what things that the patient can control. So as dietitians, we cater our treatment plan based on what's going on with the patient, what they're looking at doing with the treatment, and then obviously making sure we follow up to address those things as the patient improves. With a lot of the GI issues, sometimes things may change. 1 month the patient may be eating really well with taking in good fiber. The next month they're more constipated or having more diarrhea. With a lot of these GI issues, we kind of have to cater things as things change with some of the patients, especially with IBS and IBD. A patient could have a good day or a bad day, and then sometimes we have to tweak things as things come up with these patients. So it's very important to know that a lot of these GI issues take a lot of understanding of currently what's going on with the patient, taking on external factors, and obviously having a plan of how to address things as they come. I want to thank you for taking the time to listen to me today. I hope that whoever's watching this video has benefited and can see obviously the role our gut plays, and that it's a big part of our overall health. And I hope you have a good day, and I hope you feel well.
Thank you all for joining us today, and a special thank you to our panelists, Dr. Bani Hani, Dr. Diorio, and Devin. We invite your feedback on today's virtual symposium as well as your follow-up questions. Please leave us a note in the comments section of the video, and have a great evening. Thank you.